Well, good afternoon, everyone. Welcome. My name is Xavier Garcia, and I'm the Southern California Community Manager for the Foundation Fighting Blindness. I'm so glad that you could all join us today for our San Diego chapter virtual meeting. Before we begin, just a quick reminder to please keep your microphones muted during the presentation. We'll have plenty of time after for questions and discussion after the presentation, which is going to be around 20 minutes long. As many of you know, October is Blindness Awareness Month, a special time to highlight the incredible progress being made in vision research and to celebrate all of you who help move our mission forward. Your support of the Foundation Fighting Blindness funds groundbreaking research and provides real hope to individuals and families affected by retinal degenerative diseases. Before we introduce our speaker, I want to share a few exciting details about our upcoming San Diego Vision Walk happening Sunday, October 26th at the Elite Athlete Training Center in Chula Vista. This year's event is shaping up to be an unforgettable celebration of community and hope. We'll have two live bands. One is You'll See, which is an amazing group that also is one of our top fundraising teams. And the other is a mariachi band from Chula Vista High School, bringing local culture and spirit. We'll also feature high energy performances by the SDSU cheer and dance team and an incredible breakdancing show by Finest City Breaking, the silver medalist at the Junior Olympics. Plus, our science station will offer a hands-on opportunity to meet a researcher and ask questions about the latest breakthrough in retinal science. So if you haven't already, please register your team or make a donation. Our goal is to raise $90,000, and every contribution helps us bring closer to cures. Now, we have a great speaker with us today from Bionic Sight, which is a biotech company developing next generation optogenetic gene therapies to improve the lives of patients with retinal and neurodegenerative diseases. Bionic Sight was founded by Dr. Sheila Nirenberg, a professor at the Weill Medical College of Cornell University. The company builds on her groundbreaking research in retinal and neurodegenerative disease and computer vision. Dr. Nirenberg's pioneering work decoding the retina's neural code and using it to restore visual function has earned her numerous honors, including a MacArthur Genius Award. The company's current focus is on an optogenetic treatment with a novel mechanism of action that has the potential to improve or restore vision in people with retinitis pigmentosa, geographic atrophy, Stargardt disease, and other retinal degenerative diseases. We're very excited to learn more about this groundbreaking research, so please join me in welcoming our guest, Dr. Sheila Nirenberg.
Thanks so much. So you've said a little bit of my introduction already. So what I'm going to tell you about today is the treatment we're developing for RP and for other retinal degenerative diseases. And then what I wanted to do is there's something floating by on the screen. Okay, and then tell you about the results we've seen so far in our first clinical trial. And as he mentioned, talk will be about 15 or 20 minutes, and then we can just open up to questions. Okay, so the treatment builds on something that you may have already heard about called optogenetics, but our version has a different mechanism of action, which means a different way of working, which enables it to produce much better results. So what's interesting is that we discovered the new mechanism during the trial. The patients were starting to see in a way that was much better than would be expected from standard optogenetics. And so it was really exciting, and not just for the patients, but also for us. It was like a moment of discovery and realization. Okay, so let me get started, and I'm going to show you the results and explain why it works. And I just want to mention that
You're right on the threshold.
I hear some of their voices. I'm sorry.
I'll mute it.
Okay, sorry, I just was confused. Some icon floated by the screen and then other voices, but I will try to proceed anyway. Okay, so then I'll show you the results and explain how it works. And I just wanted to add that we've already presented this to the FDA, both the mechanism and the results, and they gave us what's called RMAT designation, which is like breakthrough designation. And what this means is that they'll help us fast track this through the regulatory process so that we can get this to patients that much sooner. And what it means really is that by fast tracking, it means that they'll allow us to have extra visits if we need to discuss things with them and get more guidance to move this through. Okay, so let me start with oops, I haven't even loaded this, the talk. Give me a second. Okay. Hopefully you can all see this.
Yep, we got it.
Okay. So just a quick overview of the trial. The drug is called BS01, and it's a gene therapy. It's mutation agnostic. I know many people ask about that. So meaning that it's applicable to many different RP genes and to patients with other retinal degenerative diseases too. It's delivered to the eye via a single intravitreal injection, which is done in a doctor's office. So no surgery is needed. And it's simple. It takes about 2 seconds, and the doctor would numbs your eyes so that so it doesn't hurt. Okay, and then safety data from the phase 1/2 trial that we're running now has shown that BS01 is safe and well tolerated, knock on wood. All adverse events, meaning side effects, were mild or moderate and largely asymptomatic, meaning the patient doesn't even realize there's anything, but when they go to the doctor can say, oh, there's a little inflammation starting, so so he treats it with anti-inflammatory. Okay, so now to the results. So let me start with the changes in visual acuity. And I'm going to start with a video so you can see how it was done, the general procedure. So the patient's presented with E's, so like the letter E. And the E is, either going, normal E, backwards E, upward E, or downward E. And the patient has to tell us which direction the E is pointing. This is sort of the modern version of an eye chart test. And it's, it's widely used now because it's much easier to quantify and acceptable to the FDA. Okay, so I know that some of you may not be able to see, so I'll sort of see well enough. So I'll sort of talk you through it. There's a patient here on one side, on the left side, he's looking at a screen on the right side. It's a little hard to see what it looks like. So I put an inset at the bottom that shows what the letters look like, shows the letters a little bit more clearly. So you can follow along while he's talking. Okay, so, and there's a black square covering the patient's face just to, protect his identity. Although he gave us permission to do this, all the patients did. Okay, so before treatment, I'm just going to show you this example. This patient had very limited vision. He was only able to read the top 2 lines on the eye chart. So 2200 and 2150. So the big E is 2200, if that is familiar. Okay, so I'm just going to run this so you can hear him.
Okay, so the top is very easy. The top is very easy, but begins with an E pointing to the left, and then there's an E pointing to the right. And the bottom is more difficult, but I can still, I think, figure it out. I think it's an E pointed up and then an E pointed down. E pointed up.
Okay, so he keeps going. There says now 2100, and he's going to say what he sees, but he's actually getting them wrong.
E pointed down. E pointed right. The ones below it, I have no idea. They're like just white squares.
Okay, so this is just to show you what he was able to do is 2200, 2150, and after that he really just starts guessing. Okay, so then after treatment, it's very different. He's able to read letters all the way down to 2040. So let me show you. So he breezes through 2100, 2080, 2070. And so I'm just going to show you after that, because otherwise it would be really like too many letters to listen to. Okay, so the top one here is 20. So he's going to do 2060, 2050, 2040, and then he starts to drop out at 2030.
A top row, E facing up, E facing left, E facing right, E facing down, E facing up. Second row, E facing left, E facing up, E facing down, E facing right, E facing up. Third row, this is tough.
It's tough, but it's 20/40 compared to what he did before. So
E facing up, E facing right, E facing down, E facing right, E facing down.
okay, so he goes all the way down. And then, so I'll just summarize it with this. Even if you can't read all of it, you can see that before treatment, it was just 2 lines that he could do. And after treatment, he goes all the way down. And many of these are, they're tested with many more than just 5 letters. Okay. Okay, so and so it wasn't just this one patient. So the improvements happened across the board. So what you're looking at here is each one of these columns is a different patient. And it starts, down here, it's patients are only able to count fingers. So some of the patients couldn't even tell where the eye chart was. I mean, you may be familiar with what that feels like. And, but after treatment, they could do 2100, 2150, but everybody's gaining something except for one person didn't gain. So the top plot shows the patients whose acuity was measurable on an EDTRS scale. That means on this kind of eye chart. And the mean increase was 4.7 lines, an improvement that was both statistically significant and clinically meaningful. And then several of the patients, especially the count fingers patients, also gain the ability to recognize shapes, objects, and colors. So I want to show you an example, then I'll show you the data after. Okay, so this is a patient who, okay, so here's the patient. He's looking at a screen over here in the middle. And then we have an inset below to show you what's actually on the screen. And I'll just talk you through it. So this is before treatment to show you what he can't see, okay? And he's an example of a count fingers patient. Just what that means is just if you're 1 foot away, the patient can see like 1 finger, distinguish 1 finger from 5 fingers, but it's very limited. Okay.
Please, like the oval.
There's no oval. So just pick something else. Heart, club, diamond.
Diamond.
Okay. And no color. We have to write down that you can't see the color if you can't see it. So just pick a color: red, green, blue.
Okay.
Yaki color, please. Red, green, or blue. Yaki.
Blue.
Okay. Next.
So just so you know, if you can't see this, it was red, and it was a spade. It wasn't a diamond. I accidentally covered this, so it's a little hard to see, but I'll just keep you posted. This
Heart,
is a spade.
Spade, diamond, club. Just pick. Heart, spade, diamond, or club. Somebody else. What is it?
Diamond.
So he
Okay,
thinks the
and
spade is a
color?
diamond.
Red, green.
It's like 29 blue or gray, something like.
Okay.
But it's red. Okay.
This one. 29 blue.
Blue, okay, and heart, spade, club, diamond.
Diamond.
Okay, so he sees it was a green club, and he saw it as a diamond. Okay, just to give you the feel for, he really was guessing. Okay, so that's before treatment. And after treatment, and I'm showing you one of the first times we ever did this. So it was an exciting moment because we didn't really know how it was going to work, how well it would work, or if it would work. So it's a little informal because, and the other thing is that he describes, he's not a card player. So he describes the images as he sees them. So he calls a spade an upside down heart, or heart upside down. And he calls a club snowman, because that's what it looks like to him, the round head and then the body of the snowman. Okay, so I'm just saying it so when you hear how he describes it, you'll understand. So this is a spade.
Right now is the heart upside down.
Heart upside down. That's what it is.
Right now, it's snowman.
So you can hear us all laughing because we're surprised.
The last one.
Last one.
Oh, right now it's the heart. Right, regular shape. Not the up and down.
Okay, so next one,
Heart.
can you just start another?
What about this? Right now, diamond.
And it is a diamond.
It's snowman.
Yes. I've never been so happy to see a snowman.
Next.
One more.
It's red snowman again.
Red. You said red. You say color.
So this is when we first realized that they could see color. And so it was sort of a thrilling moment. We've done a million of these tests more properly where it's all announced, but I wanted to show you the one that captures that moment of realization when something's working. Okay, so after that, once we realized that he could do that, we started making the tests harder. And so we included fruits and vegetables. And I don't know how well you can see this, but we have a very, I'm sorry, there's still, would it be possible to mute that? Somebody else was talking. Okay, so what we have is a distribution of vegetables here, fruits and vegetables. So you have like, a banana, you have carrot pointing one way, carrot pointing another way, big piece of broccoli, little piece of broccoli, tiny bunch of grapes, big bunch of grapes. So there, and pineapple and mushrooms, et cetera. So there's no way that a patient could just memorize this. He has to be able to see it to be able to get it right. And I don't want to go through, I'll go through a little of it, but if you can't see it, it's frustrating.
No. Okay. Next.
It's a mushroom. Oh, see what
Mushroom.
gets it right.
Okay. Next.
It's an apple.
Apple. Okay. Next.
It's a pineapple.
Pineapple.
Okay, he said it before I did.
Okay. Next.
Broccoli.
Broccoli. Okay. Next.
Carrot.
Carrot. Okay.
Okay,
Next.
so I'll just go through to the end, and he does pear and another apple. This one's redder, and a bunch of grapes, and he gets 8 out of, and then there's a carrot. And he gets 8 out of 9, or maybe it's 9 out of 10 correct. But of course, we've done this, a million times. So this just sort of summarizes. So we did this for all the patients who were at the count fingers level, because none of them could recognize shapes and or names. So this is the data for them. And so you see 4 patients here. If it's blue, it's percent correct is on the left side. And if it's blue, it's before treatment. If it's red, it's after treatment. And each of these blocks each of these circles is a block of 10 trials. So it's really a lot of data. Okay, and you can see the first 3, all of them can really do this. I also have time course plots of how quickly they became able to do it. They were able to do it at the first visit at 3 months, and it holds up. This bottom patient here improved much, more modestly, but 3 out of 4 improved. Everybody gained in color, and for some reason, red is the color that shows up. So a patient called us to say, "Oh my God, I realize now that my couch is red. My cousin gave me a couch. I thought it was gray. It's red." She also was able to see her pills so that she could take her pills by herself and use her stove, because she could see the LED on the stove to know what the temperature was. As a side point, but she also put us in her will to leave us her eyeballs in case we want to look at them. I know it's an odd thing to say, but it just shows the enthusiasm and the wonderfulness of many of our patients. Okay, so I wanted to tell the next thing, this is really the last part, is about patients with tunnel vision. So as you know, if you have RP, you start to lose your you start to lose your peripheral vision. And so your central vision becomes like a tunnel. And many patients describe it as like looking through a paper towel roll. Sometimes they describe it as looking through a straw. So But one thing that they have is that some of them can still fixate at a point. So they can still see a small dot. And if they can fixate, then we can measure the size of their field. Because the thing that we were interested in and we wanted to help with is, could this treatment expand the visual field? So for patients that could fixate, that means, and what that means is that they can hold their eye steady on a small spot on the screen. If you've ever done Goldman microperimetry, you know what I'm talking about. And then they can move the dots around to see, okay, how big is your field? And so let me show you, it did in fact improve their visual field. So here, the blue is the size of the field beforehand for the patients that we were able to measure this on. And the red is the size of the visual field after. So patients who were able to fixate showed an expansion in the size of their visual field with a mean increase of about 3-fold in area. And actually, we've just recently done another patient and it grew almost 10-fold. So I think it's a valuable thing to be able to see enough of your visual field. I don't have to say it to this audience. You know, if you're trying to cross a street and you're looking ahead to be able to see across the street, and then you have to turn your head to see are there any cars coming in this way or in that way. It's too many things to look through a small, narrow field to be able to do that. That's why people have to, have canes or dogs or a companion. So if you can expand the visual field, one of the things the patient described is I was able to call a taxi at night because my field was big enough that I could see up the street and to be able to see the light on the top of the taxi. Okay, so along the same lines, if their field is bigger, you'd expect them maybe that they would be able to do a maze more easily. So let me show you that. So for these same patients, we tested them at baseline before the treatment to see how they did on the maze and then after. And so I'll show you. Okay, so on the left side is the patient before the treatment, and on the right side is after. And what the maze looks like is it's dark, and then there's gray squares that are lighter. And so he has to walk on the dark path and not step on the lighter squares. So, before the treatment, the field is so small that he has to look down, and every step is a complicated decision because he can only see just barely a very small piece of the maze. He can't plan his trajectory the way the sighted person can see the whole thing and beyond, and can just plan what their path will be. So after treatment, because the visual field is bigger, he can plan his path. Then he can walk much more quickly with confidence, and he can step right over the obstacles. So for those of you who can see it, let me show you. So you can see he's stepping right over those obstacles, and he just keeps going. We just kept running the tape. So on the left side, he's barely moved like a quarter of the maze. And on the right side, he's lapping himself. He just keeps going around and around. The only bad thing about having you muted all is I can't hear your reaction. I can just see Robin's face smiling because she's done this herself. Okay, so I think he laps himself like 2.5 times. And then we measured, so this is a plot that shows for each run how long he took to do it. So he took on average about, I don't know, maybe 50 seconds, and it's 4 different runs. And then after treatment, he's down to like, I don't know, 16 seconds. So 50 seconds to 16 seconds, that's how much it was. And of course, the maze is changed every time. So there's no way he can memorize it. It's just every time it's facing a whole new thing. And then here's just another patient. I'll just run it. So here we measured the same thing. He was, I don't know, maybe almost 100 seconds before, and then he's down to maybe 30 or 35 seconds after. So it's still a big improvement. But the other thing we measured is how many errors he made. So he made many fewer errors because, one might think, okay, well, he can do it faster, but now he makes more errors. But it doesn't happen. He does it faster and he makes fewer errors. So it's an improvement in both directions. Okay. So he's already on his way, almost all the way through and on after treatment, but before treatment, he hasn't even made it to one end. Okay. Okay, so now let me just talk about that. That's the main thing that, before I say this, okay, that's the main thing I wanted to say. you know, to give you the highlights. And of course, I'm writing this up as a paper now, and so everything will be presented. And there's more data. I just didn't want to flood you with stuff. So one of the things that I want to mention is that the results were correlated, and that's what makes it robust. That if a patient can see small letters on an eye chart, you'd expect them to be able to see the details on a fruit and identify the fruit, and they could. If their visual field got bigger, you'd expect them to be able to do a maze, and they could. And so when things make sense, and you know, it makes everything robust because you know it's real. It's not like, okay, we got lucky by chance, this happened and that happened. It's the things that go together happened, and that gives the robustness of it reinforces the robustness of the treatment. And I think the FDA could very much see that. Okay. So why was this working? What is it about this gene therapy, BSO1, that makes it work? It works by boosting the activity of the ganglion cells, and this allows the signals from the retina's degenerated circuits to make the ganglion cells fire and send their signals to the brain. So BSO1 basically restores the flow of information from the retinal circuitry to the ganglion cells to the brain. So what's interesting about it and comforting about it is if in a patient who has a retinal degenerative disease, their retina is still much more functional than we all realized before. The problem is that the circuits are too weak to get the ganglion cells to fire and send the signals forward. So the patient sort of almost blocked. There's stuff, it's lying dormant, but it can't get through. And BSO1 boosts the ganglion cells so that the weak signals are enough to push it over the threshold and get the signals out. So the patient doesn't need any training. They don't have to learn to use this. It just starts to work. The patient just says, I see red. I can see those letters. So obviously it's not perfect. Nobody's driving home from the clinical trial at the end, but it's working for a very novel reason, and it's bringing benefit to people. And so it's a very exciting thing, both for them and for us. So now I just want to thank a lot of the people that were helping in the vision testing team, director of the manufacturing, and our support. Okay, so now turn on your mics and ask away. So I don't know how I should do this.
Well, what we can do, first of all, wow, incredible presentation. But yes, now's the time for questions. And I promise everyone, we will be able to answer everyone's questions. We have plenty of time. So please, what we'll do here, there's a couple ways. You can make the question in the chat if you're comfortable doing that. You can hit the icon to raise your hand, and then we'll do it that way. Or we can start, if someone would like to just unmute themselves and ask the question, we'll be able to get through everyone's questions.
So this is Dan.
I think I saw Dan's hand go up first, but I could be wrong.
Well, thank you. This is Dan, and thank you, Dr. Nirenberg. That's a very, very exciting and encouraging presentation. I wondered, I think you're preparing to go into phase 3 with your trial, if I'm not mistaken. And I wondered, in phase 3, if my understanding of how these trials work is correct, that usually in phase 3, you're really trialing the dosage that you're hoping the FDA will approve. So I'm wondering just how many ganglion cells you're targeting to activate with your BSO1 treatment. And I think you mentioned that it was intravitreal, which caught my attention because most of the optogenetics trials I know about are using subretinal, and I wondered if you might just chat a little bit about why you would use that approach for one versus the other.
Okay.
So for gene replacement therapy, like what else, like Sparks treatment, for RPE65, that was subretinal, but the optogenetics ones do intravitreal. But they don't work like this. They work in a different way. Okay, so let me go back to I'm trying to remember all the things you asked. So about phase 3, yeah, so that's the next step. Is because we got this designation, we can meet with the FDA and discuss our plans for phase 3. It's not really about the dose. So the phase 2 part of the trial, what we've done was to determine what the dose would be. So for phase 3, we would just, We would use the highest dose that we have since we don't have any.
Give me 1 second. We'll get that muted.
Okay, thank you.
From Sharon Jane to everyone, Poland, what ages are tried? Was teen female tried?
What's happening?
Okay,
Dean Lindman has left the meeting. Sharon.
is it muted?
Okay, there we go.
Okay, thanks. So what the main thing about phase 3, the importance of phase 3 is two things. One is that you do a
Currently unmuted, Alt plus 8.
a sham injection. And so so phase 1 and 2 was sort of exploratory. You're trying to figure out what we were trying to do is figure out which patients can we help the most and how well will it work. Then you decide what are called the clinical endpoints. What should we pick for our to use as the test for phase 3? They usually want one test, so we'll probably do the eye chart, visual
Yeah.
acuity.
You know that
Sorry. So we'll probably do the eye chart, and but I really love the maze and the visual field size because I feel like that improves quality of life in such a big way. And then the other thing that happens in a phase 3 is we have to do a sham injection. So for some patients, they won't actually get injected. They'll just have the needle pressed against their eye, but they won't get injected. And then 1 year after that, then we would just inject them because it's not fair to make somebody be a sham. But it's required. Right now, we test everything by before and after, but the FDA will also want treated versus sham. That's the standard way that it's done. Did that answer what you're asking? Okay.
Yes, thank you very much. Do you have any target date for when you start phase 3?
Hopefully in the next 6 months. We have a meeting, with the FDA toward the end of this year, so we can discuss, here's our plan. And then they say, yeah, okay, we approve of that. Go ahead, that kind of thing.
Okay, thank you very much.
Is it a one-time shot?
Yes, it's a one-time shot. And so that makes it easier. You just get it over with and it's done. That's in contrast to people who have macular degeneration and have to keep going in for shots.
It's also in contrast to some other gene therapies that are going on as well that use the same delivery, but seem to have to be done
Repeated.
every 8 weeks or so, moving in. PYCs moving into their next phase of clinical trials. Did you do any testing on as far as improved low vision, as far as like low vision in low light?
Oh, we did. And the patients also gained we started doing that somewhat later in the trial, that they could, but because many of the patients comment on it, that their ability to see in the dark, in dim light is much better. Like they can go out they can walk their dog in the evening and they're not dependent on someone else to help. So, some patients were able to do the eye chart with 100 lower light. But I can't remember, we only did it on a handful of patients, so I don't have all the answers for that.
Okay. And if my last question is, and I probably know the answer already, but if I'm in one trial already, you wouldn't be interested in doing the eye that's not being tried in your trial, right?
What are you in the trial? What kind of, is it a gene therapy or something else?
It's a gene therapy. It's the PYC Therapeutics, the VA001.
I see. Yeah,
It would be difficult.
it would be difficult, but it doesn't mean you can't ultimately get the treatment. So my feeling is that, it's good just I want to clear it, even if it's, and then for as many patients as we can. And then your own ophthalmologist can always give it to you, off label. I'm not sure I'm allowed to say that out loud, but do you know what I mean? Like people take Ozempic, those drugs, right? They can give it to you off label for another indication. So it's possible that you could still get it. But
this drug's not available yet, right? It's not.
No. I'm just saying once it was cleared, you'd be able to.
Sure.
I'm just saying, in a clinical trial, everything has to be so rigorous to make sure everything is checked to get that approval.
Understood.
Okay, next we're going to take some questions from the chat room. That way, if everyone can go muted again, mute the microphones. And then after we get through all of the chat questions, then we'll go we'll ask to people to go off of mute and to talk. So the first question is, Michelle, were there females in this study? And if so, did they demonstrate improvement as well?
Oh, yeah, of course. There were, and everybody gained something. So it wasn't gender specific in any way.
Can I chime in?
There's our one of our females. Yes.
I am part of the study. So as a female, yes, and I have seen significant results.
Wonderful. Okay, next question. Is there any way to anticipate how much vision a patient may regain? Do you expect similar results in patients with Stargardt's?
Well, I don't know the answer to that yet, but we just submitted the application to do geographic atrophy. So that's dry AMD, very similar to Stargardt's. So if it works for that, then we'll quickly apply to do it for Stargardt's too. So, I'm knocking on wood and crossing my fingers that I don't see why it wouldn't work for other retinal degenerative diseases, but until you do it, you don't know.
Does this treatment work with RP patients that have lost all vision?
So it works a little, but it doesn't, like gaining maybe hand motion and maybe the direction of motion. But I developed this device that can be combined with the optogenetics and for patients who are very blind. So I'm going to run a parallel clinical trial to see if that would work. It's using the retina's neural code to drive the optogenetics and send, visual signals in, because that's very important for the, people who are very blind to be able to help them. But at this point, I would say this is for people right now. It's for people who are, can see a little bit, like count fingers sometimes, that they could see this versus this. I'm doing 1 finger versus 5 fingers, but not much worse than that.
Is this specific to any particular gene? Will it work for cone and rod dystrophy?
We don't have anybody who has cone dystrophy in the trial, but it should, and it worked. Many of our patients, almost everybody has a different gene. I think we had a couple of Usher's patients who had the Usher's gene, but otherwise it's as they say, mutation agnostic, meaning gene agnostic. That's what we know so far. And that's the intent. So it doesn't have to be just one gene.
How can one find more about the study and participate in future studies? I'm in California.
You can go to our website and contact us. It's, just do Bionic Sight and click on that and you'll find it. And I'm writing up a paper on it, so there'll be information that's more available soon. But you've probably seen the most information right now, so I'm happy to share that with you.
What ages are tried? Was teen female tried?
I didn't get the last one.
Was there a female teenager that was in?
Oh, no, it was
trial?
our youngest patient was, I think, like 42, because it's a first, an early stage clinical trial. The FDA required us to start with older people, and so we did. And then, but every time nothing bad happened, and it was safe, we expanded it to, to include more people. So we have no teenagers here, but I don't see why it would be a problem.
Will it work with BBS1?
Is that a gene particular mutation?
Pamela, if you mind going off mute.
I'm not sure what the question is, whether that's a specific mutation or a specific gene that you're referring to, because it should work for it. It's not.
Yes. Yes, it is a specific gene, and they had a world event meeting this morning.
Okay,
That's
so,
it. It is bartered beetle syndrome 1.
okay. I don't know for sure. We don't, oh, I see, because are there other, you know, symptoms that come with it that are not retina related? Like, is it a more,
Yeah, it is a disease of the cilia, and it can have liver, kidney, high cholesterol, heart disease also associated with it. There are about 20 different bartered beetle genes they've found now. One, bartered beetle 6, has to do with overeating and things that can occur because of that. But BBS1, bartered beetle syndrome 1, is specific to the cilia and the loss of the rods and the cones in the eye.
I would think it would work, but they wouldn't be allowed to be in the clinical trial at this time because it has to be specific to RP. But I don't
Thank
see
you.
why it wouldn't work in the long run when we can make it commercially available to everyone.
Okay, thank you.
Are you recruiting participants for phase 3?
I'm not allowed to recruit anything because, but you know, you can always write. We're not quite ready to start phase 3. But you know, as I mentioned, in the next few months, well, I would say 6 months before we'd be ready to do it. I'm just saying, as founder of the company, I'm not allowed to recruit you. I don't know, there are all these rules, conflict of interest, but the company itself would be recruiting probably in 6 months.
Any side effects?
The side effects are a little bit of inflammation. That's the main side effects. And then it's treated with anti-inflammatories. So before the treatment, patients are given prednisone orally just a couple days before, and then they take it for 7 days after, just to make sure it doesn't, you don't get any inflammation. And then after that, it's just taking drops if you need them.
Is BS01 applicable to all retinal diseases, including Stargardt's? Are there any diseases for which it may not be helpful?
Well, yes, it should work for Stargardt's, as I was mentioning earlier, and we'll know after we do the dry AMD trial. That'll give us an idea. It won't work for things like glaucoma because you need your ganglion cells to be functional. So that's just an example of a disease that it wouldn't target. But there are lots of other things for glaucoma, and also it's preventable. And we should all get our glaucoma. We should all get the glaucoma test, including me, and feel free to yell at me for not doing it either, because it runs in my family.
Can you tell us more about the drug BS01? How does the drug energize the ganglion cells?
It's just a gene therapy, and it works. It's a little hard to explain unless you have a background in neuroscience, but it's an ion channel. So it makes the cells, it depolarizes them, so they're more sensitive to inputs coming from the rest of the retina. And that's so the depolarizing them makes them boosted, so that when then the signals come from the rest of the retina, they're already, it's like kind of giving them a leg up so that they can respond to it.
I read about glasses or goggles that you were also working on that encoded the signal to feed the optimized ganglion cells. Can you speak to that a bit?
So I mentioned that a little bit earlier, that for patients who are very blind, we would like to try to use the neural coding goggles combined with BS01, but there we'd be using it as an optogenetic protein. It's a little hard to explain, but the two together might be able to drive signals that can send normal signals to the brain. But that's really for the patients who are very blind. And I'll run a clinical trial to test that.
Okay, you might have answered this, but I always want to know side effects, things that can go wrong.
Okay, that's the inflammatory response I mentioned before, and they're all minor. They rate inflammation on a 4-point scale, and everything we've seen has been grade 1 or grade 2, and so it's been, knock on wood, no big deal. It's always scary, but this wasn't, and now I think that's the reason that it was when we were starting to do macular degeneration, the clinics were very willing to do it because we had very few side effects with the RP patients.
Is it like an eye drop for the shot or a surgery?
It's neither. It's an injection into your eye, so they'll numb your eye so you don't feel it, and then they do a quick injection, and it's literally like a second or less than a second, and that's it. And then just that one time.
Can this help with CRB1-RP? You said it was gene agnostic. I just want to make sure before I get excited.
It should. I have no reason to think it wouldn't. I'm almost sure we have CRB1 patients in the trial, but I can double check. Because it's mutation agnostic, I don't always look to see what each patient is, but we have it on a whiteboard in the clinic, so I can check.
The gene for my RP cannot be identified. Would I be a candidate?
Yeah, if you still fit the criterion that you have, it's a RP, and that you don't have glaucoma also, and you're otherwise healthy. We don't need to know the gene, so that wouldn't be a problem.
Do you expect the vision improvements will plateau or continue to improve as time goes on? Would additional injections in the future provide any additional benefits?
It's a really good question, and I don't know. And I've thought about whether, like with COVID vaccines, it works for a while, and then we got boosters. Is it possible that we could boost this? It's always a risk though that the second shot will cause an immune response. So I'd like to do a clinical trial to test whether boosters could be done. So I've done a little bit in animals, and the booster didn't cause a bad immune response, but I'd have to do a formal test, take a bunch of mice, or, I hate having to do experiments in primates, and inject them, and then, 6 months later, inject them again and see if anything bad happens. I would want to do that in animals before I did it in you, as you would want me to. So I really like that idea. I don't know the answer yet.
My daughter was diagnosed with inherited retinal dystrophy. Her vision is 20/400 in both eyes. Would she be a good candidate for this trial?
I think she would. How old is she? Is she over?
Yes, she is 20.
Okay, I think she would. So, of course, we'd have to, you always have to bring the patient in and get screened by the clinic to make sure they get to decide. I'm not allowed to decide. So I'm really the scientific director, but on the science side, not on the clinical side.
So who would I contact to get information?
Well, when we're starting
this.
Yeah, you can contact us through the website, and then we'll send all this eventually to the clinic when we're ready to recruit, and they'll have the list of people to contact.
Is there a wait list for this?
There's a waiting list, yeah.
Is there a time frame that it would be a year, 2 years, or you just don't know?
I just don't know, but I'm hoping it'll be in 6 months or 8 months, maybe, next summer we would start. But if you want to send the information and get on the waiting list, we'll put you there, and so your name will be on.
Great.
It's not necessarily first come, first serve, because you have to, meet the inclusion criteria and not be excluded, not get excluded by the exclusion criteria. But I think it's good to have your name there.
Okay, great. I am not part of the chapter, the San Diego chapter. I just happened to get this email and saw the topic, and it sounded very interesting because I'm actually in North Carolina.
Okay, well, glad you came.
Yeah, thank you for joining.
Oh, absolutely. Thank you. It's promising, definitely.
This might be a repeated question. What are the risks?
Oh, the risks right now are the issue of inflammation that I mentioned, which can be treated with anti-inflammatories.
Okay. I've tried to sign up for phase 3 and haven't been successful. Can we get on a wait list?
We haven't even started phase 3, so you haven't signed up for our phase 3. our wait list right now is really just expanding a phase 2. Because I won't know any of these things till I have the next meeting with the FDA to discuss where we are, what do we have to get, all the milestones we have to cross to be able to start phase 3. You may have written to a different trial, I'm not sure.
Does the current trial involve optogenetics only and not include the glasses with the camera and the processor?
Right now, the focus is on the optogenetics, on the gene therapy part of it, because otherwise we have to get clearance for the device. Also, everything requires approval. So I thought I could bring more benefit to people if we focused on the gene therapy part while we run in parallel a trial with the device. Look, I just want to say a side point. One of my, claim to fame was cracking the retina's neural code and using, planning to use that as a treatment to restore sight. But then the vector worked by itself. And even though I was slightly disappointed that I couldn't use my cool neural coding device, this was much better for patients. It's just one injection and it could really help. So I'd love to do the neural coding thing, but if I could help people without it, swallow my disappointment and be happy, right? So I'm just explaining my life story in parallel with this story.
Do you expect the results for an individual patient to continually improve or plateau?
I don't know. It's one of our patients recently was back, and if 5 years he was still seeing as much as he saw when he gained, but there's just no way to know. Sorry.
Would this not be advised for patients with autoimmune disease?
I don't know. I don't see why it would matter, but for the clinical trial, maybe we couldn't do it. I don't know. It depends maybe what kind of autoimmune disease you have. So I can't answer. I'm sorry.
My son had BBS gene 2, has some limited peripheral vision, but no central vision. Would he benefit from this treatment?
I don't know. The limited central vision makes me worried that he has nothing for us to build on. We need to be able to have some little bit of circuitry to be able to activate it. So right now we can't do the BBS anyway because of the confounding variables from the other symptoms. So I don't know the answer yet, but I'd be worried that it might not help him enough. I'm sorry. I just want to be honest.
Yeah, thank you. How will this work with a stem cell therapy? Would this help?
Well, it's just a different therapy. So if you're doing stem cell, you wouldn't be able to do this. If you're doing this, you probably can't do the stem cell therapy at least at a clinical trial level. Once it's commercially available, then I think you can combine things.
Are type 1 diabetes excluded?
I think at this point for the clinical trial, they are, because it's another variable. I'm sorry.
How many people will be in the phase 3 trial?
It won't be that, we don't have to do that many, probably. Maybe 18 or something that would get the drug, and then 9 that would do the sham, and then they'd get the drug after. But remember, it's then if we get cleared, then it becomes commercial and anybody can get it. So the goal is to get through it so that it's available to everybody. I know the advantage of being in the trial is that it doesn't cost anything. I understand that issue.
Will it work for PRPF31? I'm a 69-year-old healthy male.
I don't know that particular mutation, but I don't see why it wouldn't, if it's just if it's an RP mutation.
How long will be trial 3? When can it be in the market?
Let's say we have to run the trial for a year because we want to check for, that the results last for a year and that there's no adverse events during that year. So it'll still be a couple years before it can get there.
What is the website? So Sheila, can I just put the link in the web in the chat maybe so everyone could click on it? Would that be okay to do that?
Sure. Can you find that? But just,
Yeah.
oh yeah, because you did yesterday.
Yep. Okay. And how long ago did this trial begin? Has any patient not have it work?
The trial started in March of 2020, so right during the beginning of COVID. So we're all doing this with our N95s on and everything. It was hard. And the patients who are, very, very limited vision, like light perception only or less than that, it didn't work that well for them. They gained, let's say, the ability to detect, they could see more light and they could detect motion or maybe the direction of motion, but they didn't gain a lot more than that. And that's the reason I wanted to do the neural coding device, because for them, it may be able to improve it more.
Estimated cost of drug.
Oh, I don't know. I don't know how these things work, really. I'm just the scientist. I don't see why it should have to be that expensive, because it's just, we don't have to, it didn't cost that much to develop it. Ran a very, very efficient company, but you never know what your investors want you to do. So I will keep it as inexpensive as I possibly can.
If a patient has significant remaining vision but is legally blind, should this treatment theoretically work well along with the remaining sight?
Yeah, that's the exciting part about it. It's not like optogenetics, which would override their remaining sight or interfere with it. This will just boost what they've got, knock on wood, okay? So that's a really good question for everybody to hear, so that would open it that people at earlier stages could start getting it before they're really lost so much sight. I would love to see that happens.
Okay.
I see you pointing at me. Oh, I just waved at somebody, but I'm not sure if you could see.
I'm assuming the retina continues to deteriorate? Question mark.
Yeah, so the retina will, this isn't a cure, it's just a treatment. And so it won't stop the degeneration, but it may give you a much longer window in which your vision is still working. And then if we can work out that boosting idea that we talked about a little earlier, where you could get another shot, that would be great. That's just all the information I have right now.
Advantages and disadvantages. Can diabetes people get involved?
Not yet, because it's right now an exclusion criteria if you have diabetic retinopathy of any kind or risk of it. I'm pre-diabetic myself, so I'm very sympathetic. I'm sorry,
I see Andy has raised his hand. Was your question answered already?
Yes. Hi, Dr. Nirenberg. You sort of answered the question, but I'm understanding that this gene therapy targets the retinal ganglion cells, which is downstream of the whole light transmission process. So specifically for RP, if you're losing the photoreceptors, do you need some that are still functioning for this to work? And kind of like you said, if you lose the photoreceptors, then the gene therapy probably isn't going to work that well because it's downstream.
Right, but what I was saying toward the end of the talk is that for many patients that have these diseases, even at an advanced stage, they still have photoreceptors. They're just too weak to make the ganglion cells fire. So if we boost the ganglion cells, then those weak photoreceptor circuits will still make the ganglion cells fire. Once the photoreceptors are completely degenerated and disappear, then it's not going to help anymore. So you're trying to catch it in but a large window over which this should still work.
Okay, thank you. That makes sense.
Okay.
I see Vinatea Freeman has raised her hand. Has your question been answered?
Hi, it's Vanetta.
Sorry.
Yeah, no, you're fine. Most of the questions have been answered. I think one question that hasn't been covered is the type of patients it's on. Have you are the patients African American descent or other minorities or ethnicities?
Well, we had, a range of patients. It's a small trial, but we had somebody who was, who was Black, somebody, it's whoever wrote, so we just took, and, somebody of Hispanic background. I don't know why I can't get the words out. It was just a range of people, but because it's only phase 1, 2, it's so small to explore the whole population, but in phase 3, we'll do more of that. Although that's still a sort of small trial.
Okay,
But
yeah, I'm sorry, go ahead.
So one of our patients who is Black, it really worked for her. She's the one who can walk her dog now in the dark and can see, her backyard, and her visual field grew. The way she described it was that she would watch a talk show, and, there's a person, the guy who's hosting the show, you could see that guy, or you could see the guest, but she could never see both at the same time. And then her field expanded, and now she could see both. So we have testimonials of some of the patients. I should put it on the website.
Okay, great, thank you. I just know that in some trials, African Americans are not included generally, so I wasn't sure how far it expanded. Thank you for that.
Oh, really? I mean, I would never, I would try to get everybody.
Yes, ma'am. Thank you.
Okay. Any other questions? Stephen?
Yes, I have two questions. One, does this improve night vision for those with RP, seeing that because of the weakness of the ganglia receptors, because of the cells growing over the retina, right, that it does cause significant night vision loss? How did the participants in the trial fare with that?
It does help with night vision. We tested patients with like filters that covered it. So it was, we could test them at 100 times lower light level than normal, and they could still do the task. But we didn't explore this a lot. But patients told us also in their commentary, that's what I was mentioning about the woman who could walk her dog in the dark in the evening, who could go into her backyard, and there were steps into her backyard, and she would normally not even venture, and then she could see them to be able to go down. I do want to mention, after all of these questions, that I can't guarantee anything, and it's always so stressful I don't want to make promises that I can't keep. That's why I wanted to show you the data so you could see for yourself. This is as transparent as I can. This is the information we have at this time. And we're all praying that it keeps holding up and that it can expand to other populations too.
I understand that this is in the beginning phases of everything so far, so there's still a lot of unknowns.
Right.
Which will lead me to the next question for you more specifically. Are you going to continue researching the retinal neural map so that may perhaps develop other treatments in the future that may be more powerful or more effective with later trials or later treatments?
Of course, I'll always keep researching and trying to do this. I'm a professor at Cornell Medical School, so I have my research job too. Although I have to say I've been mostly doing the clinical trial. I've been very involved in doing, and trying to keep that going.
Wonderful.
Can I ask a question?
Thank you. God bless.
May I add just one thing, Sheila?
Sure.
Okay. I am a participant in Sheila's study in her clinical trial, and I'm one of the tunnel vision patients. I think patient 22, and I have seen significant results. And I am now 1 year and 8 months out, and I cannot tell you how hopeful I am and how much I am seeing. And I maybe had 5 degrees of vision, and on my injected eye, I now have 30 degrees of vision, and I have increased my acuity. I've increased my nighttime vision, and I have had maybe minimal inflammation that was taken care of with the drops. I cannot tell you how excited I am by this study and by the work that Sheila has put into this study and how meticulous she is with every single detail of testing. So I'm very excited, and I look forward to seeing the future of how this can help patients with all retinal diseases. So I am very thankful to you, Dr. Nirenberg, for everything you've done for me. You have given me amazing hope.
You're going to make me cry.
Oh,
Thank
that's
you.
I'm
awesome.
crying right now because I'm just, yes. So just to let you know, I'm a participant in the trial and it's been amazing.
May I ask you a question if you don't mind?
Sure.
So how did it affect with your work? Did it improve your work abilities as well? And I'm not trying to get specifics here, but how did social abilities? Because people with any kind of blindness, they find themselves a bit awkward in social situations. How did that help you after the injection? What changes did you see in those two fields?
It gave me, first of all, I'm retired, so I don't work.
Oh, you look very young.
Well, I'm not,
I thought you know.
But it has given me confidence to travel by myself, to yes, to take transportation by myself. It has given me tremendous confidence. And just what Sheila said, to walk, go on a walk by myself, to do that crosswalk, it has given me amazing confidence to be able to do independent things.
May I ask a question to Dr. Sheila?
Thank you.
Hello? Can I ask a question?
Sure.
So, Dr. Sheila, do you plan to work with any of those new companies developing neural implants to restore vision by using the retina signal decoder you developed?
I don't know. Maybe I should. I was gonna, build it in my own company, but maybe that's the better thing, is to partner with somebody and get it going faster.
Yeah, because now you have like Neuralink or Precision Science that they're planning to restore vision for the blind. And I don't know, maybe the decoder you developed could improve their vision of patients dramatically. But thank you for your answer.
Okay, thank you. Thanks for the suggestion to go and explore that, because I plan to do it myself, but you just can't do everything. And so maybe the smarter thing to do is to license the code out to people who can make this, who can bring it to patients faster. And I can focus on what the other part.
Yeah.
Looks like we're down to the last couple of questions. Let's see here. Sorry. Marcia, do you have a question? Okay. Dan, do you have a question?
I do, thank you. I was wondering, I think when the FDA was reviewing the Luxturna treatment, the gene therapy for LCA, I believe one of the things they did was to hear sort of testimonies, if you will, from participants to help them understand not only the quantitative data and the endpoints and such, but to understand the impact, the true impacts to quality of life and how it affected people. I wonder, when you meet with the FDA for, say, your phase 3 or whatever trials, would you anticipate they'd let you bring people like, obviously participant number 22 here on the call would be a great, certainly be a great person to have along. I've wondered, do you know, does the FDA in general, do they want to hear from trial participants to actually get a human view on what's going on with it?
I don't know. It's a good question. I'll ask when I have the FDA meeting. I mean, one thing we do is we we film every trial, everything, every test we do is filmed. So that way anybody can look at the data and evaluate it themselves to see, you know, if they wanted to. But it is nice to also have people tell their story. How has this changed my life? So I'll see if I'm sure they'll be interested.
Okay, question by Doris for patient 22. Can you estimate how many years earlier your vision compares with?
I honestly don't have any idea. I mean, I always kid with Sheila that I can drive now, but I don't think I can drive. So I stopped driving 8 years ago, and but I would say probably it's taken me to at least 5 years before when I could see better.
Marcia, do you have another question?
I just I'm trying to do it on a cell phone and I have no idea how to do it. So no, but you answered my question in the chat. Somebody put it in, you answered it. So, but I do want to say thank you. She was wonderful in every way.
Thank you, everybody, for coming too. And it's really great to meet you all through the questions, and I really appreciate it. And thanks, Robin. You're so wonderful. Keep in mind, I didn't know Robin before the trial. It's not like, you know, I paid her off to say those things. She's a true patient, you know.
And you've been an amazing doctor.
Well, thank you again to everyone for joining us today, and a very special thank you to Dr. Sheila Nirenberg and the team at Bionic Sight for sharing their inspiring work and vision with us. If you missed any part of today's presentation or you'd like to share it, the recording will be available on our YouTube channel, the Foundation Fighting Blindness YouTube. I put the link in the chat. It'll be available before the end of next week. You can also email me directly. As you all got the email invite, you can simply reply. If you'd like, I can send you the link that way. Or if you have any questions that I can relay to Dr. Nirenberg, I can do that too. Or any questions about the foundation, our San Diego chapter, research, upcoming events like the San Diego Vision Walk. Thank you for all those who are not from San Diego who are on the call and got to be here with us today. Thank you all again for being part of this community and for your continued support of the Foundation Fighting Blindness. Have a wonderful
Thank you, Xavier. Thank you so much for hosting.
Thanks, Xavier.
Thank you,
Dr.
Xavier.
Nirenberg.
So
Bye-bye.
much.
Bye, everyone.
Thank you.
Thank you.
Thank you.
And Kimmy too.
Thank you.